Good day, everyone. Welcome back to Rio, day 3 for the second session. I've clearly replaced Dr. Tung, who has run off to the lab to present his live case of HD grid mapping and complex VT for session 3 later this morning for me, but I guess later this evening for some of us in Europe. This next session will be a presentation by Dr. Dinesh Sharma, who will be presenting on totally leadless CRT. I'd like to take this opportunity to welcome back our fantastic panel, Dr. Lucas Boersma from St. Antonius Hospital, who just presented an amazing live case for SICD, Dr. Michael Gold from South Carolina, and Dr. Dinesh Sharma from Florida. Please remember that these sessions are live, and we would like to hear from you in the audience. Please submit your questions to us, and we'll do our best to address as many of those as we can. And so I'd like to turn the session over to Dr. Sharma, who will be presenting on totally leadless CRT.
Thank you. And thank you, course directors, for the invitation. So I'm Dinesh Sharma. I'm an electrophysiologist at NCH Healthcare System, Naples, Florida. And I'm going to talk about totally leadless CRT. So I have no disclosures. So the audience is well aware of the potential deleterious effect of chronic RV pacing. Approximately 30% of patients will develop pacing-induced cardiomyopathy within 4 years, and CRT upgrades, they account for a quarter for all CRT implants. The leadless pacemakers with Micra and now Avior, they continue to expand, and these patients will also carry risk of developing pacing-induced cardiomyopathy. YCRT, which is an acoustic-based LV endocardial pacing system, could be an option for these patients to stay leadless. So I thought it was interesting, and I would like to share with the audience the brief history of this innovation. Actually, I was fortunate enough to have a discussion with Dr. Echt, who was one of the founders of this technology, and she's an electrophysiologist. So when they started working on this technology, their main aim was to use ultrasound energy for defibrillation. But during the process, they realized that actually works very well for pacing. It can safely and consistently pace the receiver electrode. And other interesting fact, which I found very amusing, was that the tines, which are the fixation mechanism for these electrodes, the inspiration was a tick bite, which led to this innovation. So the YCRT system, it needs a co-implant device such as ICD or pacemaker RV lead, a receiver electrode, which is a very small, maybe a size of grain of rice, a length of 9.1 millimeter and diameter of 2.6. It has a battery which goes in the left mid X-ray line, very much like a sub-Q ICD, and a transmitter which has ultrasound crystal to send the ultrasound signals to the receiver. So the way it works is first the YCRT system, it senses the pacing stimulus, and once it's sensing pacing stimulus, that triggers the crystal in the transmitter to send ultrasound energy to the receiver electrode, and this electrode converts the ultrasound energy back into electrical energy, and it paces the LV endocardium. This whole process takes around 2 to 5 milliseconds. And some of the earlier data, this was a non-randomized study of 35 patients, select LV. The 97% of patients were able to achieve implantation success. And at 1 month, 97% were able to have CRT, and then 94% after 6 months were still having a benefit of cardiac resynchronization. There was a significant improvement in ejection fraction, decrease in end-systolic volume, end-diastolic volume, and QRS duration. The SOLVE CRT is still ongoing, but the analysis of the roll-in patients was published last year at Heart Rhythm Journal, and it again was consistent with what we saw with the SELECT LV, that there was a significant improvement in ejection fraction, decrease in systolic and diastolic volume, and QRS duration. So the implantation process for this YCRT, it's a 2-stage process, but it does require screening, just like sub-Q ICD. And in the screening, you use the standard ultrasound probe to look for a window without lungs and rib in intercostal space. And usually it's from intercostal space 4 to 7. And once patient is passes the screen, Then stage one is the implantation of the transmitter and battery. So I usually prefer to do it a day prior to the electrode implantation, but some centers, they prefer to do it in the same setting. So as I said, it's very similar to implanting sub-QICD. You make a mid-X-ray incision, create a pocket where the battery goes, and then using tunneling technique, we connect the cable to the battery. And this transmitter, it is secured to the intercostal muscles. And the goal is the transmitter should be able to send ultrasound energy without the bone or lung in the window. The electrode implantation is kind of a unique process. So it's implanted in the LV endocardium. It's done using a 12 French delivery system, which can be introduced to the left ventricle, either retrograde aortic approach or transeptal approach. The most of the implanters now prefer transeptal approach. So once you have the endocardium of interest, like mostly, let's say, LV lateral wall, one would evaluate the site for pacing, looking at the angle and distance from the transmitter. And then subsequently, we will anchor the device. And when the anchoring is complete, we release the electrode from the delivery system. So it anchors well with 5 Newton tines. It's a passive device, so that's something very unique, that this is supposed to last patient's lifetime. And the animal studies have shown that full endothelialization can happen in 30 to 45 days. So this is the cine images of patient we did in our center, which was first in the United States with totally leadless CRT. And this patient was 81-year-old with, even though EF was borderline, but he was presenting with CHF exacerbation. He had left buttock branch block and end-stage renal disease. So we had implanted in this scene, as you can see, that the micra is there, and also the transmitter and the battery, which was implanted a day before. So this delivery system, and we checked this area, and we found that the distance from the transmitter and the angle was acceptable. And then injecting contrast to confirm the apposition of the delivery system with the endocardium. So once we confirmed that this was the site we wanted to anchor the device, then we started anchoring. And in the beginning, one can see the denting of the endocardium along with the needle, and you can see the contrast is following the needle. And once the anchoring is complete, then the needle does not have any contrast flowing into it, and you can see the contrast only in the LV endocardium. So that's the confirmation of anchoring, and we do want to confirm the anchoring in 2 views. And once the anchoring is confirmed, then we release this device, this electrode, and after that we had first only leadless CRT, at least for our center and the United States. So patient's QRS width decreased from 216 to 178 milliseconds, and his ejection fraction in 6 months follow-up had normalized, and he was symptomatically doing much better. So in this LAO view, you can see the micra and the RVOD, and then there's the transmitter. Is the LV electrode and subcutaneous batteries. So far it has been interacting and functioning very well. So along with our experience, there had been a lot of cases in Europe, and the case series published last year in Europace, there was, again, as we've seen with the conventional devices, that the YCRT was consistent in decreasing the QRS duration and improving the ejection fraction. So last month we presented abstract at Singapore APHRS, which was again our collection of the cases from US, Europe, and Australia. And the objective of the study was to assess the technical feasibility of achieving totally leadless CRT using the MICRA and YCRT systems. So the previous European case series was 8 patients, and this was 14 patients. So patients were mean age 69, predominantly male with non-ischemic cardiomyopathy and atrial fibrillation with wide QRS. And the indication was infection in 5 patients, upgrade of chronic MICRA leading to cardiomyopathy was a 5, de novo implants was 3, and the failed CRT system was 1. So success was achieved in all 14 patients. So 4 patients who were in sinus rhythm received MICRA AV, and 10 with AFib received MICRA VR. So all YCRT devices were able to detect the MICRA pacing output and deliver synchronous LV endocardial pacing, resulting in successful cardiac resynchronization. No unforeseen device-to-device interactions were observed, and there was one acute complication recorded, which was due to premature detachment of an unanchored vice electrode. Another electrode in that patient was safely implanted without clinical sequelae. So in 12 out of the 14 patients, we had a 6 months follow-up, and there was, as we have seen with the previous studies, that there was a consistent improvement in LV ejection fraction, decrease in QRS duration, and there was a trend towards improvement in CHF symptoms. So based on the data we have and experience we have with the leadless pacemaker in the right ventricle and the YCRT in the pacing the LV endocardium, Dr. Paul Roberts at Southampton University Hospital, he is the principal investigator for single-arm prospective multicenter study for patients who are candidate for CRT and will be receiving the RV leadless pacemakers such as MICRA or AVIR with YCRT. And the primary endpoint is freedom from major complications related to device or implant procedure throughout 6 months. And the next question with the advancement of the totally leadless system is, can this also be used in left bundle area pacing or conduction system pacing? So there was a recent publication from Europe where they had 2 animal models and 8 human implants from France, UK, and Australia. And most of the patients had non-ischemic cardiomyopathy, and they were successful in all 8 patients to have LV septal pacing. And 4 patients, they were able to target left bundle branch block. By the way, all these patients were done using transseptal approach with the guidance of DE or ICE. This is one of the EKGs and the fluoro images, thanks to Dr. Allison from Australia. So he did show that you can significantly narrow the QRS, and because the peak LV activation was less than 90 milliseconds in the lateral precordial leads. So this was suggestive of left bundle branch capture. So the implantation of the YCRT in these patients was successful in all 8 patients, and bi-V pacing was confirmed on 12-lead ECG. The temporary LV-only pacing, which can only be done with the use of the programmer, was achieved for further narrowing of the QRS, and there was significant decrease. In 4 patients, the peak LV activation time suggested capture of left bundle branch. And the 6 months, the results are durable with median LV pacing of 98.5%, 75%. There was a symptomatic improvement, and 50% of patients with 6 out of 8, there was evidence of LV reverse remodeling with decrease in systolic and diastolic volumes. And you can see in these EKGs that there is significant decrease in the QRS width, and the EKG in the slide, the last EKG in the C, it shows LV only pacing. So that's the pure left bundle area pacing. So the next step is again a a single-arm prospective multi-center study to assess the effectiveness of the left bundle area pacing. And Dr. Rinaldi is leading this study from St. Thomas Foundation. And this will be, again, very interesting study, which because left bundle area pacing is becoming the primary source of pacing in US. And I think if we can have leadless pacemaker, which can achieve that, it would be incredible. So achieving totally leadless CRT using micro and Y CRT system is technically feasible with good clinical outcomes. And the TLC study will further give us some more data and prove that. And I'm very excited about the leadless left bundle area pacing, because that could be the future. Thank you.
So I want to thank Dr. Sharma for an incredibly interesting presentation. I mean, this technology has developed very quickly, although I remember hearing about this years ago. It's amazing to see the progress. I guess the first question I'll have for you, and then I'll turn it over to the panel for some of their questions, is after implant, you said endothelialization of the pacing button takes about a month to a month and a half. Do you do any prophylactic anticoagulation over that time, or is it small enough or not that much of an issue that you don't have to worry about it being prothrombotic?
Yeah, so a lot of our patients, they have AFib, so they're already on anticoagulation. So then it becomes pretty straightforward what to do. But patients who does not have indication for anticoagulation, we usually give them dual antiplatelet therapy for 90 days. So the profile of this device is very small that I feel comfortable just giving aspirin Plavix for 90 days.
Okay, and I'll just actually take a moment to remind the audience to please submit your questions to the main stage area question module on the online segment. Dr. Boersma, I'd be interested in your thoughts on this.
Well, I've used the technology a few times in my patients. I was part of some of the early trials that were done when it was still looking for initially as sort of a niche indication for people that could not receive CRT in a regular way. And we've shown in those first experiments or first patients that this is indeed feasible. And I think it's interesting to see how now the indications are developing, looking at this to combine it with other types of devices, looking at left bundle branch area pacing, seeing completely leadless CRT is very interesting. So I think that the proof of concept of that, I think, is very interesting. So we're showing now, or the investigators are showing now, that this is feasible over a wide range of indications and issues that you can have with transvenous devices. I had some concern after a while based on battery longevity of this, because that turned out to be still a technical issue, that actually the battery sometimes wore out very quickly in patients with large left ventricles. I don't know how this has evolved now, because I did see this as a potential drawback for patients to use this as a real competitor for the transvenous devices. Has that changed now?
Well, so they have the technology, which would be rechargeable batteries. So that's the next step for them, and it does make sense that the rechargeable batteries, so you can have a longer battery life. But the one good thing, I know it's still a challenge, because sometimes thresholds are high, because as you said, with large left ventricles. But the silver lining is that electrode, once it's implanted, that's there. So you're not doing any intravascular procedure. So what the challenge is actually a subcutaneous battery replacement. So I think the rechargeable battery, and just like we have seen with experiences of the other manufacturers that did have premature battery depletions, and they have overcome it. So I think that should be an easy hurdle to pass, because there is technology out there. Other manufacturers have gone through the same problems or challenges. So I think that should not be a long-term problem for the technology.
Dr. Gold, I'd be interested in your thoughts.
Yeah, I mean, I'd have a little more caution about the battery issue. I mean, with ultrasound, it's not nearly as efficient and energy source. So even in the best hands, the battery life of this device is, a third of what it is for most other devices. So, I mean, we've done a few cases in the past. I've actually been on the steering committee with these folks, since the beginning, and it's exciting technology, but it's growing technology. I mean, what's interesting is now combining it with other devices to get newer indications and newer ways of using it. I mean, the left bundle and the and completely leadless systems are very intriguing options, and being able to blend them together at some point will be important. But yeah, I think it's a great concept, proven concept, but we certainly need more data. I don't think we're ready, certainly for prime time for this. Certainly, none of this is approved in the United States yet.
So one of the questions that's come up in the online forum from Dr. Mokadas is, how many times would you end up seeing VT develop within this population? I guess to take that a step further, if you're putting in a completely leadless CRT and a patient does develop VT that requires you to upgrade to an ICD, does the presence of the subcutaneous probe or ultrasound generator and battery pack limit your use of SICD, or are you committing then to a transvenous ICD on top of the leadless CRT?
So certainly if you have VT, you need a transvenous anyway.
Well, you need an ICD, let's say, but are you committing to an SICD, or are you committing to a transvenous ICD as the device if you've gone completely leadless to start?
I guess I don't think many of us would use an SICD if we have documented, or at least monomorphic VT.
Right, but I mean, if you think to the future where I guess this will be talked about a little bit in the next session, potentially during the symposia, but if you have a leadless device capable of ATP that you can combine with a SICD, maybe that's coming in the technological future, can you also combine that with this device to develop or deliver CRT on a regular basis?
Yeah, so there has been a case where they have done sub-Q ICD along with the YCRT with a totally leadless system. So, but yeah, we are not there yet for once the technology developed for the communication between the SICD and the leadless pacemaker in the right ventricle. Yeah, I mean, that's a possibility in the future, but it's not feasible right now.
Okay. Another question that's come up online is if you don't achieve target resynchronization with your position, how would you tackle that clinically?
So so that's why we spend a lot of time choosing the right site. So you want to spend a lot of time, just like the way you used to put the CS leads. Similarly, you need to choose the right site. But so going forward, my goal is to implant in the LV septum. Try to get the left bundle area pacing. And so far, the experience from Europe is very encouraging. And a good thing is that in that case series of 8 patients, they actually did the mapping of the LV septum in 4 patients. So you can use 3D mapping system. You can try to map the left bundle area and choose the best potential you want to, and then implant the device. And so the goal is to get the best site at the time of the implantation. So because you can change it's very easy to change, I would say, the battery and the transmitter. But once the electrode is implanted, the intention is for it to be there. So far, the experience of the last 8 patients with left bundle area pacing, I think that would be the long-term solution, that you have a good left bundle capture and you continue with that.
So I guess a similar question is the question around the stability of that electrode. So is there any risk of peri-implant dislodgement of the left ventricular electrode, or is it usually pretty secure once you've implanted it?
So it's usually very secure once it's implanted. So so as I said, it's based on the tick bite, and it's very hard to take the tick out. And same way, once it's anchored, it's just going to be very hard to take this device out. But the dislodgements have happened intra-procedure, when the anchoring was not confirmed. And so one has to make sure that the needle or the tines are well in the endocardium. There's no contrast, going towards the needle. And once you confirm that in 2 views, it's a pretty secure device. It's not going to come out. And going back to the question regarding the patient developing VT in future, yes, I mean, you have concerns regarding doing VT ablation in these patients, for that matter. You have a small device. So as the animal studies have shown, that the endothelialization can happen 30-45 days. Yeah, I would definitely like to wait at least 6 months for doing any VT ablation of patients with with a leadless device. But similar concept, just like the way we implant, like when I implant Watchman, I like to wait 6 months, at least 6 months if I had to go for AFib ablation. So similarly, I think waiting for endothelialization would be the right approach. That's what I think, but obviously the data will show it in the future.
I think another advantage is with these systems is that it's endocardial pacing. And multiple studies have shown, acute studies, mostly hemodynamics, that endocardial pacing is better than epicardial pacing, which we get with a CRT lead. So the left bundle is a little bit different, but for sort of a CRT alternative, going through the endocardium is better, and plus you're not limited by your veins. You can go anywhere on the left ventricular surface. So you should be able to get in. The data have suggested you get very nice resynchronization with that system.
Yeah, I think that's a very important point.
No capture of the phrenic nerve, as far as I know.
Yeah. Yeah, and I think the other part being that you can be a little bit more targeted, right? You're not limited by the anatomy of the coronary venous system in terms of where you can leave the lead. So it gives you a much more tailored procedure in terms of where that actual resynchronization occurs. And I guess we're seeing that now with the left bundle area being targeted during these procedures. So I think we're coming up on the end of session 2. I want to thank our amazing faculty for such a wonderful discussion, and Dr. Sharma for such an intriguing presentation. It's been an exceptional morning here on day 3 of Rio 2022. Our next session is a symposium with Dr. Boersma looking at the SICD, the Ask Me Anything session, which I think will be incredibly informative. And then following that session, we have a live case with Dr. Roderick Tung doing complex VT mapping. So I think that that'll be a great afternoon, or at least evening or second half of the session for everyone else. So I want to thank everyone for joining us for session 2, and we look forward to seeing you here for the rest of the program.